Statins are seen as a necessary drug, right? So, for example, one patient who was taking statins said, I don't take drugs. For me, being on tablets is an inconvenience, and unless I'm absolutely convinced they're necessary, I won't take it. But he was taking statins. So he felt that people feel that they are an absolutely necessary
That's
drug.
Very interesting.
This podcast is part of the GK Media Studios Creators Network, helping people tell their stories. Become a storyteller today and learn about our podcaster network at gkmediastudios.com.
So welcome to When You Choose You podcast. In today's episode, we have Dr. Paula Byrne from University of Galway, the research department, I guess.
Yes, I'm in the College of Medicine, Nursing and Health Science. Yeah.
Very good. Thank you so much for being with us. Thank you so much for allowing the world to get a little bit of more understanding of what research means and what brought you to researching about statins, because I want to say how we came across with each other, or how I came across with your research, was when I wrote an article about statins and statins versus lifestyle when we approach cholesterol and heart health. That's my main area of work, metabolic health and heart health. And I saw your research. I came across with your research and I was like, I can't believe that it's someone in Ireland doing that. So here we are going to dive a little bit deeper into it and see what we can bring for people to learn a little bit more about the statins and what role they play, and if they play the role what we think, and in that direction. So thank you.
Yes, you're welcome. I'm delighted to be here. Thank you.
So first question, what prompted you to research about statins?
So as I have to go back a long way to kind of describe that, but it's kind of in my background. My mother was a pharmacist and she passed away last summer, and she was very interested in the overuse of medicine. So that was
as a pharmacist in overuse of medicine.
In the overuse.
I like that. Yes. I like where we are going.
She was particularly interested in the overuse of antibiotics. And she worked right up into her 80s. So she was still given out about the overuse of medicine in her 80s. Literally on her deathbed, she actually had a conversation with the GP.
God. I love that. That's passion.
So when I went back to do a PhD, I knew I wanted to work in the area of kind of medicalization and overuse of medicine. So I needed a topic and I needed to hone in on a particular medicine. So I chose statins because they're very widely used, and because there already was a bit of controversy about their use. So I wanted to really dive in deeply and see, well, what is the evidence to support that use? Yeah.
And tell us, what did you discover in 20 years? Did you tell me that 20 years?
I'm 10 years looking at this.
Okay, 10 years.
I'm looking at this topic, and I'm still going. So there's lots still to delve into.
Yeah, so we'll stick with this.
Yes.
What did you discover? And then I want to ask you a little bit what a research means. And
great.
I'm very curious about that area.
Yes. Great. So I've done a number of papers. I have 6 or 7 papers on statins, and they're looking at statins from all sorts of different directions. So, the prevalence and use and who uses them, why they use them, the changes to clinical guidelines and how that has affected the use of statins, and then the actual association of LDL cholesterol, which is, people would call it bad cholesterol, and cardiovascular events. I also have done a little bit of what's called qualitative research. So talking to patients and doctors about why they use or prescribe statins. So the first paper that I brought out is called a cross-sectional analysis. We have a very good data set in Trinity in Dublin called TILDA. And TILDA is the longitudinal study on aging. So it looks at the same group of people over time, and every few years it records a whole lot of information about them. So I was looking at basically who's using statins and why are they using them. So the group that I looked at were about 5,000 people, and they're considered to be nationally representative, so they're representative of what's out there in the community.
Was national?
Yes.
Okay, national.
Yes, yeah. And they were age 50 or older. So what I found there was that about 30%, about 1/3 of people are taking statins aged over 50. And obviously statin utilization increases with age. You know, you wouldn't be surprised with that. And then I found that about 2/3 of statins are used for what's called primary prevention. So that means somebody has not had a cardiovascular event, heart attack, stroke or whatever, but they're considered to be at risk.
Because of the family?
Not necessarily.
History?
No, there's risk calculators. So it would have to do with your age, your sex, your weight, whether you smoke, and then as well your cholesterol levels, you know, and your blood pressure. So they'd be the main things considered in a risk calculations to say, right, you are.
It's interesting that it's not the family history, because from what I hear from my clients, and actually a cardiologist, what I came across with close enough in a chat, and was the first point risk was the family history of
it is
hereditary.
I'm not aware of any risk calculators that formally use that as part of your risk calculation. I could be wrong,
that's why I wanted to see what a researcher is looking for when you are looking at those figures.
So it's a calculated risk, and well, technically it's a calculated risk, but very often patients go into GPs, as I'll kind of come to later, and the GP will see a high elevated LDL cholesterol and they'll say you need to go on a statin. But so we found that 2/3 of people taking statins had not previously had a cardiovascular event. It was for primary prevention. But there was a big difference in sex. So nearly 3/4 of women who were taking statins were taking them for primary prevention. And just over half of men. So there's a difference, you know, there. We also looked at the different factors that were associated with taking statins. So unsurprisingly, age, you know, the older you got, the more you went to your GP, the more other drugs you were on. So that's called polypharmacy. If you were married or in a living with somebody, you are more likely. I call that the nag factor. So somebody's, are you taking your statins?
Okay.
But there was a little bit of disorder in the thing. So as I described before, cholesterol is only one of the risk factors, and it should be seen as part of a whole, you know, span of risk factors. But we found that people who had, you know, only high cholesterol as opposed to any other indication were quite likely to be taking statins. Now, that's not surprising, but that's actually not technically how statins should be prescribed. There was a hint in that research that patients were not being prescribed on the basis of having their risk actually calculated, you know, using one of those risk calculators.
Rarely you will come across with someone who actually calculate the risk and then
So that's something that a GP would do, and it's, you know, it's quite a simple thing. You just you could do it yourself online. I
heard that in UK it's actually coming now as part of the health screen. Once you are over, I think it's over 45, if I'm not wrong, and the GP does exactly.
Will do the risk calculation. Yeah. So there's one called Q-Risk. There's a European one called SCORE. You can look them up online, and if you know your own figures, you can actually, you know,
do it yourself
and find out. It's quite good fun, and change your weight and see what that does and change everything. The second thing then I looked at was, obviously, GPs are guided by clinical guidelines. So I looked at the changing clinical guidelines over a 30-year period, from the 1980s up to 2016 was the last one I looked at. So those would be recommendations that are brought together using expert opinion and evidence, you know, what studies are out there and that kind of thing. But the guidelines change over time. So in general, clinical guidelines, and this is across the board with medicine, as clinical guidelines change, they expand the eligibility for a drug use. So and this was the case with statins. So I looked at European guidelines from 1987 to 2016. And I found that in 1987, if I took that same group of over 50s in Tilda and I looked at all the different factors that they had, only 8% of them would have been eligible for statins in 1987. By 2016, 61% of them would have been eligible. So that kind of blew my mind.
Okay, and Paula, tell me, who is responsible or who dictates the guidelines, or what dictates the guidelines?
Yeah, so these guidelines are the European Society of Cardiologists and the European Atherosclerosis Society. I think it's EAS guidelines. So they'd be European experts, probably a lot of cardiologists. The guidelines, it's interesting to me what evidence is used to support them, so I would argue in a lot of guidelines, there needs to be more robust methodology of systematically reviewing the evidence, because you will see, if you look into the guidelines, you'll see that the same study is cited, so it's like there's a favorite study and it's cited for years and years and years. So I'm not sure if the methodology of guideline development is always optimal.
Okay. Because anecdotally, we are saying that is pharma behind.
Yes.
And all that. And this is going on in, like, the podcast is for the people out there.
Yeah.
And they are probably not familiar with the terminology and all that. And that's why I want to make that clear, because I'm not against anything what is helping the medicine, but overuse is what I'm against too.
So I mean, in terms of pharmaceutical influence, that is another huge factor. And I think in guideline development, you would have to look at the authors of guidelines and see, have they declared their conflicts of interest? We all have to declare conflicts of interest when we publish, So there tends to be a lot of, declarations of conflicts of interest. So somebody has been a speaker for a pharmaceutical, blah, blah, blah.
As you know, I was working in the system, so I know exactly that can be done.
So you would have to kind of look at, and it's not something I've done, but you would have to look at the specific guideline, who are the authors and what interests they declared.
Yes.
But I wouldn't be surprised if there is either explicit or not explicit, there is an influence. I'm sure there is,
Okay.
So we did a little calculation on that finding, so the moving from 8% to 61% eligibility. Now, that doesn't mean 61% were taking statins. As I told you, we found that about 30% were. But we look at something called the NNT, which is the number needed to treat. So how many people would you have to give a statin to prevent one heart attack, one stroke, whatever? So that's called the NNT. So we found that the NNT in the early 90s was, according to those guidelines, you would treat 40 people to prevent one cardiovascular event. As the numbers expanded in eligibility, by 2016, you would have had to treat 400 low-risk people, I'm talking about now, to prevent one major vascular event. So again, from the perspective of the state who's paying for drugs, they're getting less bang for their buck as eligibility expands.
And that's a huge aspect to take into consideration.
It is a huge thing. So you have to consider, so that's low-risk people. If there are 400 low-risk people taking a statin, you'll prevent one event. And then you have to consider, because it's something I'm quite passionate about. We hear about, children who can't have their scoliosis surgery, or people who are, caring for, either children with disabilities or adults or older people with dementia or whatever, and they can't get respite.
Exactly. And people who are on the waiting list for an appointment with a specialist. Yeah, exactly. Yeah. And they wait years for,
So that does bother me. If depending on who we're actually reimbursing, if we're reimbursing low-risk people on statins, is that the best use of our resources?
Yeah.
So then,
surprising point. I never thought of that, but look.
It
makes a lot of sense.
It makes a lot of sense, and it really motivates me. I had a coffee with a colleague yesterday who has a little lady with Down syndrome, and she needs language and speech therapy. She's, now
And autistic children are a category that is so hard to get.
So it's the use
for
of scarce resources correctly is certainly motivates me for some of this work. So we then did a big, what's called systematic review of all the trials that looked at the effectiveness of statins. So what we did was we tried to find any randomized controlled trial, and maybe we'll talk about that later, what that is, but they're considered to be the gold standard of trials. So we looked for all the randomized controlled trials on statins that had been run for a long enough period, over 2 years, I think it was, and that had a large enough number of participants, so 1,000 people or more. We brought all of those together in a systematic way throughout ones that weren't eligible, and came up with a kind of overall finding on the association of statins with various outcomes. Now, we chose 3 outcomes to look at. One was all-cause death, so death from any cause. So if you're taking medicine, really, what you care, you don't really care what you're dying of if you're going to die. So all-cause death is considered a really good one to look at, because it's, you're either dead or you're alive. There's no debate about it. Then we looked at heart attack and we looked at stroke. So we looked at those 3 outcomes and to try and see how did statin therapy improve the likelihood of having them. First of all, we found our first big problem was what's called heterogeneity. So that means you're comparing apples with oranges, with bananas, because one study is looking at one type of statin at a certain dose in a certain group of people. The other study is looking at a different statin at a higher or lower dose. So it's quite hard to bring together all your findings. So it's a huge problem within statin research that the trials are very different from each other.
And that's, do you know, I probably you don't, but I'm just thinking, it's that such a common thing to be in research in general?
It is a problem.
Okay.
It is a problem. And we have statistical methods, and I'll tell you a little bit about that to try and deal with that to a certain extent. But it is a big problem. And with statins, they are now off patent. Nobody is going to pay for a trial. So what we really need is a whole lot of trials of the same statin in the same dose, in the same type of people, and then you'd have a much better idea.
From a research point of view, when do you have enough evidence? So, for example, how big has to be the group of people who you apply for or your research?
It depends on what you're measuring as your outcome, and how common that is. So that's called power in a study. So you need the study to be powered big enough. So if you're looking at a very, very, very rare event, you would need a massive study. And sometimes they are unfeasible. So pharmaceutical companies are supposed to, or drug developers are supposed to do what's called phase 4 trials, which is after the drug has been given approval. Then you look at it in the real world, and then you can start picking up the very rare events. But more often than not, phase 4 trials are not run because nobody makes them do it. This is another bugbear of mine.
I can see that happening a lot.
Why would you? You've already got your license.
Exactly,
Anyway, so going back to this, what I call systematic review of all the trials in statins. So we found that the reduction overall in all-cause death was 0.8%, so less than 1%. The reduction in heart attack from taking, so this is comparing the group that takes statins to the group that don't take statins. So heart attack was reduced by 1.3% and stroke was reduced by 0.4%. So they're quite small numbers, and these are called the absolute risk reductions. But very often we're presented with a bigger number. So, your listeners might hear something like statin will reduce your risk of heart attack by 1/3. So where that comes from, it's called the relative risk reduction. And if I could just explain it like this, if I said to you, I had a trial and 10 people who were not taking statins had a heart attack, and 5 people who were taking statins had a heart attack. I can then say, well, statins reduced the risk of heart attack by 50%. From 10 to 5 is 50%. But what I didn't tell you is that I have 100 people in the trial. So only 10 people not taking statins had the heart attack and 5 that were taking statins. So I actually, in absolute terms, I reduced the risk by 5%. So very often, risk reduction in any medicine is presented as relative risk reduction when it should be presented as absolute risk reduction. And it's a kind of nerdy point,
yes,
but I would love if people understood that for any drug you're taking. What is the absolute risk reduction? That's what you need to know. And then decide, do you think that it's
That's fascinating. And thank you for explaining that in such a clear way.
Okay. The other thing we looked at that in that study, in that systematic review, and this was published in JAMA Internal Medicine in 2022. So I'm the lead author on it. So if you Google me and JAMA Internal Medicine, you'll find the study. So the second thing we looked at was this idea of a linear relationship between lowering LDL, bad cholesterol, and that's not the term we should be using, but it's an easy term to understand.
Yeah.
So if LDL cholesterol is a very causative factor in cardiovascular disease, what you should see is that in all the trials, the more you reduce, so the trials that had greater LDL reduction should have greater reduction in all-cause death, a heart attack or stroke.
Yeah.
So we couldn't find this linear relationship. So we did something that's called a meta-regression. And this is one way of kind of getting around what I was talking about earlier, the apples and oranges of the different kinds of studies. So we did this meta-regression and we couldn't find this linear relationship. There's sort of maybe not a linear relationship, but we found that some studies where you had huge reductions in LDL cholesterol, you didn't have huge reductions in the outcomes,
in the events,
whatever it was. So they were a bit all over the place. So we can't say that there isn't a linear relationship. We can say that we failed to find one in those studies, So that was really interesting to us as well, because, that is the basis of clinical trials. The more you reduce, your LDL, the greater the benefits. So we did not find that. The other thing then to consider is that if you're thinking about, well, I'm talking about an absolute risk reduction of 0.8% in all-cause death or whatever it is, heart attack. People worry most, I think, about stroke, actually.
Yes, exactly.
Yeah, so it's a 0.4%.
I mean, probably stroke and heart attack.
Probably, yeah.
Especially in women entering menopause, and I hear a lot of heart attack fear.
Yeah, there's a lot of talk about that at the moment. Yeah. But again, going back, so if you consider, and I'll use cliches here, but if you have a, 60-something-year-old overweight man who smokes compared with, a 50-something-year-old slim woman who does her yoga or, walks, doesn't smoke, does whatever, they're at completely different levels of risk.
Exactly.
So then if you take the small benefit from the statins, the higher your risk, the greater the benefit, So, but you still need to know, well, what is my baseline risk? So again, if you look at all those risk calculators like QRisk and just bang in the figures that and then you can add taking a statin and it'll reduce, show you how much you reduce your risk by. So the next question then for me was really asking, well, why? If we know that the evidence is that they reduce it by quite a small amount, your risk of cardiovascular events, why do people take them and why do people prescribe them? Why do GPs prescribe them?
Very logical question.
Yeah. So I did some, as I said, a qualitative study, and it involved interviewing. Now, I have to say, it was a small number of people, so I don't know if this is representative of everyone in the world, but it was quite insightful. So,
was Irish people?
Irish
Okay.
GPs and Irish patients who were taking
residents,
Yes,
Ireland residents.
Yes, who were either taking
Yeah.
statins or had been prescribed statins
Mhm.
and weren't taking them.
Yeah.
So I was trying to find, what do people think they're doing when they're taking statins?
Yeah,
and
very good point.
what are the
Yes,
perceptions
yes,
that
yes.
they have? So the findings, I first of all found that, as I mentioned before, high cholesterol was seen not as one of several risk factors that might contribute to heart disease, but it was considered to be a problem in itself. Now, that might sound like a picking,
No, for me,
being really
it makes,
picky.
yes, exactly.
But it's not. So it was seen as a disease in itself, which is
Yes.
not. It's a risk factor.
Okay.
You know.
Yeah.
So, for example,
thank you for mentioning that, because it's so true.
yeah,
It's so like, okay, I have high cholesterol.
yes, it's a thing in
Yes,
itself.
it's a thing. Exactly.
Yeah.
Exactly, yeah.
So it is a risk factor. So, for example, one woman, she said, "Oh, there's a history of cholesterol in my family, not so much a history of heart disease. It was a complete shock to me that I might have cholesterol problems." Right?
Mhm.
So there she's saying that it is a disease.
Yes,
basically.
Yeah.
GPs were very much of the mind that the recommendations were evidence-based and scientific, but there was a little bit of ambivalence in you know, the GPs that I interviewed. So the GPs would say, well, the targets have dropped in terms of the levels of LDL that are considered,
yes.
you know, to be healthy, and you can't argue with the figures. And then I had one GP who was saying, you know, where do you draw the line? Do you stop at 85? Do you stop at 90? You know, and one told me a story of a woman he had treated. She was in her 70s and she'd very high LDL. I think it was LDL that he was talking about. But she couldn't tolerate the statins. So she came off them and she lived to be 97 or something. So he was like, well, that was a learning to me, you know. So statins are seen as a necessary drug, right? So, for example, one patient who was taking statins said, I don't take drugs. For me, being on tablets is an inconvenience. And unless I'm absolutely convinced they're necessary, I won't take it. But he was taking statins. So he felt that people feel that they are an absolutely necessary drug.
Very interesting. For someone who is passionate about the behavior behind the health, like, oh my God. That's so...
Okay. So that's the kind of belief.
Do you think that is fear? Or is the respect towards the authority of the GP or cardiologist?
I'd say it's probably both. And I think that cholesterol is, that idea that it has become a disease in its own right has been promoted, you know. And it's now in everybody's DNA that that's what people think.
And again, feel free to say that I can't answer that or something like that. It doesn't. Do you, how that became a reality? I'm very curious.
Yeah, and it's actually something I did look at within my PhD, but I haven't published on it. And, you know, the process of what's called medicalization, so how something becomes identified as a problem that can be solved by medicine. So there is a whole history from the very beginning of going right back to the 50s. So I think it was Roosevelt was the American president who had a heart attack or stroke while in office. And this brought a huge amount of attention to cardiovascular disease. The long-term study called Framingham, which was in this town called Framingham in America, was set up, and it identified that cholesterol was one of these risk factors, you know. So that was the start of it. And then, of course, when there's a problem that a pharmaceutical drug can solve, the drugs then came out in the 1980s, and they were very heavily promoted. And the GPs I interviewed would have said that back in the day, they were very heavily promoted. So it kind of became, and then we became very obsessed with numbers. And I've been talking about numbers, I know, but we're very obsessed with know your numbers, you know what your cholesterol, what your blood pressure, whatever. So that was a kind of a cultural shift as well.
And it's still very much.
Very much so, very much so, yeah. And that's considered to be the right and the responsible thing to do, to know that stuff. So I think there's a whole cultural and commercial influences, I would say. And then when something gets embedded in how people think, it's hard to walk that back.
Yes,
you know,
yes.
my research then in these interviews, there was also a belief that people thought that statins would completely protect them from cardiovascular disease. Now, as I explained to you before, we're talking about risk reduction. Okay, so you have X number of people who are taking statins will have a heart attack or die or have a stroke, and Y number of people who are not taking statins will have heart attack, stroke, or whatever. So it's the difference between those two people. But people that I interviewed really thought, that's it, I can't have a cardiovascular event if I'm taking a statin.
Yeah.
So I have a quote there from a woman. She said, I hadn't really thought about it like that because I think I'm dealing with it. I never thought of the fact that I could have a heart attack, stroke. It's a bit scary when you think that you could have heart disease even if you're taking them. That's what she said. That's a whole different ballgame, she said. So that was...
And it's very relevant in the context of this podcast and in the context of my work.
Yes.
Because I say when you choose you. So the choice element is kind of taking out.
That's
from
right.
this.
Yes, I think, yeah.
Yeah. So I'm hoping that this episode is bringing a little bit more, at least to question.
Yes, well, I mean, I'm always asked, do you think I should be on a statin? Well, I don't know. It's not, it's not, I'm not you or your GP, but I would say to people, go talk to your GP, ask to have that risk calculation done.
Mm-hmm.
And then look at, the findings that I've described there and the risk reduction. And then say to yourself, because people have completely different risk perceptions. What I might find risky, you might not,
Yeah,
or
exactly.
I might rather risk the cardiovascular event rather than the side effects. You might rather risk the side effects rather than the cardiovascular event. So it's
the same with pain or anything.
Exactly.
Like it's very perception based, personal perception.
People
yes.
are individual, and we, and I think absolutely people have the right to make those decisions once they're informed, once they're well informed. But I do have a problem, as I said, with low value care and the state spending money on arguably wasteful
something,
so, and I'm not saying that all statin reimbursement is wasteful. I'm saying in some people it probably is, in low risk people, and that the state could spend its money better.
Yes, okay,
Yeah.
I like that point too.
Yeah.
Yeah, and it's very interesting in the context of working with a health coach, for example, or on lifestyle management. It doesn't matter, it's a lifestyle coach or health coach. You take the statin if you feel like that's the right thing for you, but you don't put all your efforts, like all your risk to bed because you take a statin.
Yes.
So you really need to adjust the lifestyle anyhow if you want to do something about your heart.
Yes,
health
and I think that was kind of, there was a few of the patients I interviewed where they were going, I'd rather have my rashers in the morning or whatever, and they thought that they were offsetting.
Exactly.
By taking statins, you can't offset a bad diet. I don't think.
Yeah, absolutely. Yeah.
And I love a rasher. So no,
but exactly, in balance and in moderation.
So there's a whole thing about what people think statins are doing.
Yes. Okay.
Yeah.
So back to a little bit more research, because I'm very curious now, and I have you here. I'm going to take advantage to understand that.
Yeah.
So when you do research, I had that question about how big the
study
needs to be and how many people. And now it's clear for me that depends very much on the effects on. When you say systematic review, what that means it's not a study.
Yes.
It's a lot of studies.
Yes.
Okay.
So this is again, a very nerdy, but love of my life is systematic reviewing, because you can't really know the answer to any health question unless you systematically review the evidence. So you'll hear on the media all the time, and it drives me crazy, a study has found blah, 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 blah. And the more exciting the finding, the more traction that study gets. You don't know if there's not another 100 studies out there that say the complete opposite to that study.
Yes.
Do you know what I mean? So systematic reviewing, and I work with a unit in the university called Evidence Synthesis Ireland, and we're now a unit for developing trial and systematic review methodology. So how you do these systematic reviews. So it's a bit like, I say, it's a bit like paint by numbers. it's evidence by numbers. So it's a very certain way of doing. So for example, I want to look at statins. I want to look at it in adults. I want to look at these particular outcomes of all-cause death, heart attack, stroke. So I will first of all decide that I'm going to search certain databases, which are medical research or whatever. I'm going to use certain terms that will allow me to pick up every single study on that topic. I could end up, so it'd be quite common, you could end up with 1,000 studies.
Yes,
right.
Okay.
So you've already written out your criteria. I wanted it to be a randomized controlled trial, and maybe we'll talk about what that is
exactly,
after.
Yeah.
I want it to have run for more than 2 years. I want there to be more than 1,000 people. So the first thing then is I bring them, and there's software to help us with this. We bang all of those 1,000 studies into the software. We review the title and maybe the abstract of all of them, throw out the ones, and this is quite quick, and you get quite quick at it when you're doing a lot of systematic reviews, throw out the ones that are not relevant, and then maybe you're left with 40 studies. Then you're going to read them in their entirety, and you're going to throw out another 20, for example.
Okay.
And then you come down to, so for example, I had 21 randomized trials in this systematic review. Now I have 21 that have fulfilled my criteria that I pre-specified, so I don't trick myself and allow myself to cheat. And I like that study. I'll bring that one in. So it's a way. And then you do everything in duplicate. So I work with a colleague. We'll both screen them.
So to keep the objectivity of
So we bring them together then, and we extract whatever data that we've decided, again, pre-specified. And before you ever do any of this, you will have written a protocol, and you ideally will have published that, and the protocol is your plan of your research. Again, it's stopping you cheating. So we bring them together, we extract the data, then we might do statistical analysis like, we did do in this one. Sometimes the way the studies are reported are too different, and you can't do a statistical analysis. So you just report narratively what it said. This study said this study said this. But we were able to do what's called a meta-analysis and meta-regression in our study, in our systematic review. Then you go and you start looking at the trials for what's called risk of bias.
Okay.
So how were the trials themselves run? And that's a whole other thing. And again, we've software to help us with that. But you're literally going through, how did they randomize them? How did people know that they were taking or not taking? Was there a way that people could figure out that they were on treatment? And there's all different sources of bias. So we do that, risk of bias assessment. And then we use that further step to assess the certainty of evidence. So we come up with, statements like, we are moderately certain that statins reduce heart attack by a small amount. They're almost formulaic, those statements as well. So that's when you get to the end of your systematic review. But there's a big process all the way through.
Now I understand what you are still at it after 10 years.
Yes, exactly. And still training. Because there's so much
on the
it.
go. Yes, exactly. My next question, listening to you, was how long is, because you said about people and how big complex is, and then I was thinking, I hear a lot about the statins, bringing back to the statins, that it's relevant in time. So their effectiveness or efficiency is...
That's a very good point. Yes. Yeah. So I would say that is not, it's possible, but it's not underpinned by good evidence, that statement.
Okay.
And
okay.
it's actually something that my most recent study, and it's just been submitted to a journal, so hopefully I'll be able to tell you more about that.
Hopefully.
But
we'll bring you back.
we
After.
did, yeah, we did consider looking at, so you would have to take the data from the trials, which are run for a certain length of time, and you'd have to do some kind of modelling to extrapolate the effect over time. It is an argument. I don't think it's underpinned by evidence, but it actually is possibly my next project.
Okay.
So,
that would be interesting because
Yes.
I hear a lot of the recommendation is for the rest of your life because the more you take, the less is the risk.
yeah. I mean, bottom line is,
The longer you take, not the more
longer.
you take.
Yeah. The bottom line is we only have those randomized controlled trials. That's all we have. Nobody's going to run new trials. So any information we have has to come from them. Now, what you're probably referring to is what's called an observational study. So if you follow people over time, right?
Okay, so that's an observational study.
Yes. And the problem with that is that, and maybe I'll explain the randomized trial now
First,
because it would kind of explain this. So if I take two groups of people and I want them to be as identical as I can have them. So I have the same age range in group A and group B. I have the same sex, whether it's 40% men or is in both groups. I have the same kind of health status, so I want the two groups, ideally, in an ideal world, they would be exactly matched.
In the context, just hold on there, don't forget, in the context of cholesterol, it's relevant to be the same sex.
I'm talking about trials, right? So if I'm running a trial on a statin, say I'm running a statin trial, right? I want two groups of people that are as closely matched. So I'm not putting all the healthy people in one group and all the, young people in one group and all the old people in another, because then you wouldn't, you're going to have other factors that are going to influence the outcomes. Yeah. So I want them to be identical, the two groups, except that one group is taking whatever it is you're studying, the statin or drug intervention, and the other group are not. And there's a whole thing about how you randomize, and, again, I won't bore you with the details. So that way, that as far as we possibly can know, that the effect that you see on the thing that you're measuring, so whether it's heart attack, all-cause death, is likely to be associated with the intervention that you've given, with the drug you've given one group and not given another. Now, if you just have one group of people in an observational study and you're following them over time, you don't know that, for example, there's something called the healthy user effect. So people who take statins are more likely to be runners, have a good diet,
Yes, okay.
So that there's other factors, and that's called confounding. So is there something else apart from the statin over that long period of time?
Yeah.
So you can't know unless you do a randomized trial of an intervention. Now, sometimes we can't run trials. It's just impossible. It's not feasible. And it might be an intervention that, running might be the intervention. Well, you know that you're running or you're not running.
Yes,
do you know what I mean?
yes,
And you can't run a blinded trial that. So there are limitations to what we can study, but observational studies are not considered as high quality as randomized trials.
Okay. So then the next was, what is the, what did you say? It's a randomized control trial, and then was the observational.
Observational,
yes.
Yeah.
Okay.
Yeah.
Okay, so when I hear a lot in nutrition, especially, now I'm moving a little bit because I am curious about the research part, there is not enough evidence to prove that whatever, or whatever diet, or what do they, and especially related to nutrition.
Yeah.
I hear that a lot, and it seems like there is not enough evidence, and we cannot even have enough evidence ever to prove that something is. So when the lifestyle is associated with less risk or lowering risk of, there is not enough evidence. Or something like if you're going more in not holistic necessarily, but natural therapies,
Yeah,
or there is not enough evidence. So what is your takeaway in that?
Yeah. So I would direct your listeners then to the project that actually is my day job, which is called iHealth Facts. And iHealth Facts is a website where people can put in questions about, health interventions, like you're talking about diet or supplements or drugs, prescription drugs. And we'll go and do the research on it. We'll do a systematic review on it. Now, more often than not, we'll come up with exactly what you said. We can't find enough evidence to prove one way or the other,
But what means enough evidence? So what is enough?
Exactly. So for example, we did one on, does lavender help you sleep? And for that, there actually were some trials, randomized trials, small trials. So we're always looking for randomized controlled trials.
Yes, turmeric was another one, what I heard a lot. Like, there is not enough evidence.
So you might come up with a few randomized trials, but they might be small. They might be subject to what I described before, risk of bias, So very often we'll come up with, we don't really know. This is what we do know. And I'd ask people, check out iHealthFacts.ie. Give it a good plug there.
Yes, we'll put the link in the description.
It's a great website. Yes. But it's a perennial problem. But I don't think there's a black and white answer to saying what is enough evidence. I mean, I've described the evidence on one of the most studied drugs in the history of pharmaceutical. We still don't have enough evidence. I'm saying we don't have enough evidence one way or the other. So I think what's important is that people do know what it is, what the state of the evidence is, and maybe it is observational studies, and as I said, sometimes we can't run trials on a particular topic. Maybe it is. And then go, well, in balance, I think I am going to take this or I am not going to take this, and we bring other things to decisions. We bring other values to decisions like that, which are important, So as I said before, you and I might have a completely different perception of risk or, whether we could be bothered, doing a particular diet or going for a run or whatever it is. So the other things come into the factors to the decision, but there is no black and white. People, it's very easy to say on either side of any argument, there isn't enough evidence or there is enough evidence or the evidence says, and there isn't enough evidence. It doesn't matter what the topic is.
Yes, it's very relative.
It is. It's relative, but it would be good for, and it surprised me with iHealth Facts, some of the things that there are actually trials on. So we did a review. I had never heard of this, and I'm probably pronouncing it wrong. You can tell me, of something called ashwagandha.
Ashwagandha.
Yeah.
Yes. Yeah.
So we did a study on that, and I was surprised. There was actually quite a bit of trials, mainly from, I think they were mainly from the Middle East,
India
and Asia.
I
think
that's very popular.
Yes, of course. It's Indian ginseng, isn't that right? Yeah. So there was something that I thought, never heard of that. No, there'll be nothing, And then on the other hand, one of the early questions we were asked, and was quite fun, was do dock leaves help with nettle sting? Because that's a real Irish thing. You rub the dock leaf on the child and whatever. And of course, there were no trials. And then I found only recently somebody was doing it as teaching people how to run trials, and they ran a trial on nettles and dock leaves. Okay. I was like, wow.
Very interesting. So all the insights.
But also then you have the commercial impetus for. So is somebody going to make money out of the thing? Then there's, the pharmaceutical industry run trials because they can afford to.
And you prompted me exactly towards my last bit of so who is paying for the research? I'm not saying who pays you. In the context of economic state, pharmaceutical, commercial, who is paying for a research in general?
Yeah, it's a mix, and it depends on what you look at. Like the university in Galway, does a lot of basic research, particularly in the area of medical devices and bioengineering and all of that. And my understanding is that then when the basic research is done, if it's something valuable, then you'd have a commercial company come in and either take it over or do a partnership. I don't know exactly how they work, but certainly with statins, there were always pharmaceutical trials, you know. Some of the basic mechanisms of cholesterol, how cholesterol work, would probably have been done by somebody in a lab, in a university or whatever. And then when there's commercial potential for it, that changes it. That's my understanding. Anyway.
Yeah. And a little bit of your personal takeaway in an aspect. Do you think, because I often find myself explaining to my clients that it's actually the fact that the GP or the cardiologist or the whoever is the medical care professional is driven by the insurance, and they have to be covered. And that's why it's easier to give someone a pill, because that's something that you can control and cover yourself up with, than to say go home and change your lifestyle and you have no control with what happens. It's about lowering the risk, obvious, but is that from your perspective an element?
It's hard to know. I think it probably is. I think GPs have clinical guidelines coming at them right, left and centre, and it's very hard to keep up with all the different, drugs that they're supposed to know about and understand. So it is probably easier go with the clinical guideline, which says if somebody's cholesterol is over X, then they should be blah, blah,
Okay, so it's more clinical guideline than...
Well, you see, that's what I would know about.
Yes,
so but I would imagine that everybody's been afraid of being sued, of, if I go out the door and fall down the stairs.
Exactly. Yeah.
So it's another problem. And I think you would probably have to talk to GPs about how they feel about that.
Yeah. Exactly.
But I think
it will be the next... The next step.
Okay.
Wish me luck with that, because it won't be an easy one, but I hope it will be. Exactly.
I work with a lot of GPs. A lot of my research, I've co-authored with GPs, and I've great respect for God, they're at the coalface, and I think in general they're trying to do their absolute best, but they are overwhelmed with guidelines.
Totally. It's interesting. It will be interesting to find out what is actually behind, because it's easy for us from the outside to judge by not getting an appointment, not getting treated with enough time in an appointment and all that, and then they only know what's going on actually. Okay, so thank you so much.
You're welcome.
Is there anything else what I missed asking, or something what you were prepared with?
No, I think I would just conclude by saying that, you look at this from 2 points of view. From the personal perspective, as I said, go and find out what your own risk is with and without statins. Ask your GP if you're concerned about, taking a statin or not taking a statin, and then make your decision based on an informed choice. And
that's a very important point.
I think so. And then I think the big picture is, should the state be covering what's called low value care? And it's not just statins. There are other drugs that are probably represent low value care. I have a PhD student. He's based in Trinity in Dublin, starting his PhD on looking at this issue of low value care and waste, and how we spend our money better in healthcare. So that would be
that's very interesting. That's we are going to cover that, I promise, because I have someone in mind who accepted my invitation, so he's the right person to talk to. Great. So exactly. Okay, so thank you so much for being here and accepting my invitation, and I look forward to putting the information out there.
Great, thank you very much.
Thank you.